Meera ma'am, what are the common problems patients come to you with?
If you take the majority of the patients, they come in with urinary leakage.
Ma'am, in urology, if you see, a lot of things have become very minimalistic. Like everything is changing from large things to small things.
Is there a difference between bladder emptying at all between men and women?
Hydration is very important topic, ma'am, because what happens is patients are suffering from increased frequency and urgency and they get scared to drink water.
Like once said, your skin and your bowel is the mirror of what is internally happening in you. That is what we need to watch out for all the time.
I tend to tell all my patients that taking a bowl of curd every day or at least buttermilk every day will keep your gut health and the bladder health better.
All women between the age of 21 and 65 should have a pap smear. Unfortunately, in a country like ours, though there are guidelines, we do not have a robust recall system or reminder system for patients to come through to have a pap smear done.
What people have a misconception is robot does the surgery. No, robot doesn't do the surgery. It is a surgeon who sits on the console. He moves the arms, the robotic arms move inside.
But like computers, they are what you give in will be given out. So garbage in, garbage out. So it should be as good as the operator. It just does not make the surgery better on its own.
Hello, I am Dr. Sandeep Bafna, consultant urologist and genitourinary reconstructive surgeon. Today we have someone very special, very close to me, with whom I worked for many years. She is a gynecologist, urogynecologist with a special interest in pelvic floor health and advanced minimally invasive robotic surgery. With her immense clinical experience and with a patient-centric approach, she gives immense confidence to the patients and by restoring function. Today, we have Dr. Meera Raghavan on our podcast, and I'm very happy to have you on our podcast, ma'am.
Thank you. Thank you, Dr. Sandeep. It's a great honor and pleasure.
Thank you so much, ma'am. Ma'am, before we start talking about today's topic, there is a very simple thing I need to ask you. We both work on very intimate areas and which patients hesitate to talk to us about. What made you choose urogynecology as your subspecialty?
Very interesting question. The reason why I chose urogynecology is while doing the core gynecology, I found our women are facing inevitable problems of aging and menopause because half their life, or at least more than a third of a woman's life, is spent after menopause. The problems related to the urogynecological aspects tend to surface and worsen, and there is no signposting for them to whom to go to, and the suffering is untold and they continue to do so in silence. And this is one of the reasons I chose urogynecology as my core specialty, to help out these women achieve a good quality of life and live their life with dignity.
Absolutely, ma'am. We notice that a lot of patients tend to make these symptoms and signs of urological suffering as normalized as their age-related symptoms. How do you make them comfortable when they come and meet you in your room?
It's basically having a patient listening ear. Most of the time they feel as if they are not listened to or their symptoms are disregarded as being normal. So listening out to them makes us have a good rapport and build our trust with them, and they start telling more than what is on the surface. And if you explore further, you will be able to pick up a lot more problems which are either due to their menopause, their aging, or other comorbidities like obesity, diabetes, and hypertension, which worsen the urogynecological problems, and that helps us treat them better.
Absolutely, ma'am. Meera, ma'am, what are the common problems patients come to you with?
If you take the majority of the patients, they come in with urinary leakage. Basically, they feel that the sudden leakage of urine without or with the sense of urge, where they go very frequently to the washroom and they're not able to hold on till they reach the appropriate place and time. And the others complain of leakage of urine, which is a sudden gush, quite embarrassing when they cough, sneeze, laugh, or even climbing upstairs. There are certain patients who come with recurrent burning sensation, pain in the genitalia, or difficulty in passing urine, and at the same time have on probing come out with the fact that they do have similar discomfort and pain while having intimate sexual intercourse as well. Apart from that, people do come with complaints of something coming down the vagina, which is like a descent of the bladder, the uterus, or the back passage, which further worsens their symptoms of either difficulty in emptying the bladder or difficulty in emptying the bowels. So these are the majority of the patients who come to me with either a worsening gynecological issue or a urogynecological problem.
Absolutely, ma'am. And what are the common doubts patients ask you? What are the common doubts or myths, what you feel they regularly ask?
The two main doubts or the fears with which they come is it kidney failure or is it cancer? So the first aspect is to start reassuring them that it is neither, but if you leave things like what they are, say for example a recurrent urinary tract infection, it can damage the kidneys and can lead on to renal failure. So the moment there is problem with the waterworks, they attribute it to kidney failure, and the moment the symptoms of burning or itching don't go, they attribute it to cancer. These are the common fears or doubts women generally approach with.
And do you feel that when patients come to you saying that there is a blood in my urine or
Yes.
the menses, they become very anxious and talk to you
There are
about
two kinds. One, they are hyper anxious, they come immediately. The others think, okay, I probably started having my period again, and they kind of bit complacent or laid back, or they're so scared that if they come to a doctor, I will diagnose something, so they don't want to talk about it even to their own daughters and sons. So there are two spectra of patients who approach this whole thing of blood in urine or blood in the vagina.
And when they come to you in your consultation, and if somebody, their family members are there along with them, are they comfortable talking to you, or they need to talk to you in privacy?
Nowadays, women come forward and start talking about it in the presence of their kith and kin. There are still some of the ladies who say, if only I had a daughter or my daughter was here, I would have revealed this. I'm not able to even tell my husband or tell my son. And there are patients who come in pretty much really worse situations of a prolapse or severe incontinence with diaper rash, which they have kept a secret from the entire family. So now with the raising awareness and the shedding of inhibition, women are coming forward, but it was not the case a decade ago.
Fantastic, ma'am.
So with regards to, now that we have discussed women, are men forthcoming with these problems? What are the common issues you see amongst men?
A lot of men come to us, ma'am. Regularly they meet us. Previously, we used to say only elderly people used to come to our clinic. Anybody who is more than 60, 70. But at present, the things are changing a lot. We have 20 years of age people coming to us in our OPD with a lot of symptoms. So if you categorize based on the age, if elderly people are there more than 50 years or anybody, they usually face difficulty in passing urine. They notice that their flow has become a little slow. They need to frequently get up in the night. And they attribute that problem to aging, and they don't come forward very frequently until unless they start starts getting disturbed in their daily routine. And then you have people who are in age of 30s to 40s, who are many of them who are sitting job or an IT professionals. They start complaining of back pain, testicular pain. They have difficulty in burning sensation. Post intimate relationship, they have severe pain in passing urine. So these are the kind of patients who come to us. And then in regular patients, we have a lot of patients who come with stone diseases. So stone disease can be common in both men and women. So nowadays we started seeing more frequently because of our advanced imaging techniques. We have a lot of patients who come with 3 mm stone, 4 mm stone. They become very anxious and they come to us with the reports. And then we have other set of patients who have difficulty in passing urine, where they have some blockage in the urinary passage known as urethral stricture. So these are the common problems who come with us, come to us. A lot of patients feel elderly people especially, that getting up in night is very frequent and normal according to the age. So normally they should be able to pass urine once or none at all. If anybody is getting up more than once, that is not normal and that should not be normalized at all. Second, noticing blood in the urine should not be normalized. So many of them correlate saying that I had last night this food, this beetroot, this medications I'm taking. Because of this, my urine color is red. It may be some infection. No, do not normalize until unless we are sure that what is going on. Poor flow of urine or straining or taking too long time, people feel that is my age related problem and this is absolutely normal. I don't need to consult anybody. These are the problems I notice patients coming to us with a lot of end stage problems, end stage complications when they come to us.
So I'm glad you pointed out that increasing the awareness has made them come forward. So that is something optimistic. So in the current decade, in the last 10, 12 years, how do you think the urology practice has changed? Is there anything you notice?
Ma'am, in urology, if you see, a lot of things have become very minimalistic. Like everything is changing from large things to small things. Like that in urology, which were open surgery, now became laparoscopic surgery, and now we have robotic surgery. Second, the diagnostics, the MRI, the CT, and the reporting with the help of artificial intelligence has made it very clear that this is a problem you guys have, this is a treatment which is to be needed. And there are advanced reconstructive techniques which have come up in present era, or the reconstructive armamentarium has increased, where the urethroplasty or the urethral stricture, which was diagnosed and managed very badly in previously, things are getting better and patients have much better choice, treatment options, and things are getting better with urethroplasty techniques.
So is there a difference between bladder emptying at all between men and women?
100%, ma'am. Men need to put a lot of more pressure to pass urine. They need to cross two obstacles. One is prostate, and then the next obstacle is the urinary passage, and that is a long urinary passage. Compared to men and women, men have almost 25 centimeter of long urethra. Women have just 4 centimeter of long urethral length. So men have to cross two big marathons. They have to cross from bladder to urinary passage to pass urine. So they take a lot more time to pass urine. They need to put a lot more pressure to pass urine. And if they have some obstruction, some obstacle there, that increases further problems.
Interesting that you mentioned marathon, because women just need to relax their pelvic floor. They don't need any buildup of bladder pressure to empty the bladders. So I now understand why gym is more suited for men and yoga for women.
100%. Exactly the same way, ma'am. If the women don't have a prostate there, what are the other problems they start noticing, they start facing, which is more common in them?
That's again a very good question, because women normally, as I told, don't need extra bladder pressure. So they don't need propulsion to release the urine, but they need what is outlet relaxation. So it's like a trap valve. If the pelvic floor is like a trap valve, it opens up and the urine is emptied from the bladder. So if the trap valve is very tight, say for example they have pelvic floor spasm due to past history of sexual assault or violence or a repeated trauma or previous surgery, then the trap valve mechanism does not relax itself well, then they'll have difficulty in emptying the bladder. So when you approach women with difficulty in emptying, it's slightly a different understanding from that of men. It is not an organic obstruction or a physical obstruction in the pathway. It's more of a functional obstruction there, or something which is stopping the passage. Say for example a large fibroid in the uterus, which acts pretty much like the prostate and pressing on the urethra, or any mass in the pelvis, or in elderly women as they age, because of the lack of the estrogen, the passage becomes too narrow from inside. It's just like dust getting inside the kitchen pipe and becomes narrow, and the stream becomes narrow. Similarly, they can have these problems and have difficulty in emptying the bladder. So the pathology is completely different compared to men. It's more of a functional aspect and different reasons for those obstruction.
What are these functional problems related to the bladder and the urethra, ma'am, in females? and the women?
It can cause a myriad of symptoms. Say, for example, if a woman has a bladder which is not having enough capacity to hold, they will typically complain of frequent visits to the washroom and an urgency sensation even when the bladder is half full, what we call the sensory urgency. So the bladder doesn't need to be full, but they will be rushing to the washroom because the bladder is very sensate. This can happen with either ulcerations within the bladder, not necessarily due to infection, because of the inflammation within the bladder. Infection can cause inflammation, but not all inflammation is due to infection. It could be the lining which is kind of disrupted in the areas in the bladder, what we call bladder pain syndrome, and that can lead to a functional urgency, burning sensation, inability to hold on for a long time, and frequent visit, especially in the night. They're woken up in the night to rush to the washroom. And with regards to the urethra, as I already mentioned, if the trap valve mechanism of the pelvic floor doesn't relax enough, they need to push on it like men, and that creates even further tightness of the pelvic floor, leading on to holding back of urine in the bladder, which we call retention of urine, and then can lead on to far-reaching consequences. So I would attribute majority of the problems in women related to bladder and urethra, around 60 to 70% is functional, majority of them rather than anatomical.
That is very nice point, ma'am. 60 to 70% of the problems are functional. Lot of women undergo regular urethral dilatation. What is the message for them?
So message not only for our women but also for our practitioners, I guess. Before you do a reflex job of doing a dilatation of the urethra, just hold back and think, why is this woman having the problem? A thorough examination of the genitalia, and even before that, a very sensible, sensitive history taking is very, very essential. A young woman cannot have obstruction in the urethra and be subjected to dilatation. More likely she's having pelvic floor spasm, and the history would be sexual assault or sexual abuse as a child. We need to see beyond the horizon. We need to see behind what is in the surface to get back to the bottom of these things, so we avoid dilatation. And one thing both of us would agree on is urethral dilatation itself is a traumatic procedure, and if not done properly and if not done correctly, can lead on to further scarring, and what was eventually a functional problem can now be converted into a structural problem. So probably producing more work for us, but nevertheless.
The common message I need to give everybody today is don't undergo urethral dilatation unnecessarily without a proper evaluation or meeting a proper urologist or urogynecologist. The next set of patients who come to us, ma'am, even we see a lot of women patients in our clinic, they come with incontinence. They feel that before they go to the washroom, they're not able to control and they start leaking. That is very embarrassing situation for the patients, and when they come tell us also, they feel very sad, they're not able to open up. How do you talk to these patients? How do you understand that this is the incontinence is because of bladder or the urethra or your body weight, or there are a lot of reasons which can affect? Can you highlight us what are the reasons for incontinence between the age group of 20 to 40 or elderly people, so that patients understand that these are the reasons?
Yeah. Like I'm sure it's the same case in your practice with men as well, but women unfortunately are more prone to urinary leakage compared to men, because at one point in time, anybody above 50 years, there's a 70 to 80% chance that they will experience incontinence in their lifetime. And incontinence, for benefit of everybody, is involuntary escape of urine with or without a sense of urgency to go and use the washroom. So these can be of varied types. So incontinence with urgency is related something to pressure building up in the bladder, or the bladder trying to be over smart, what we call an overactive bladder. Whereas when they leak when they cough, sneeze, or laugh or exercise, it is to a weakened pelvic floor, and that is called stress urinary incontinence. I have to emphasize to the viewers that when I say stress incontinence, many of them ask me, I'm mentally stressed, I've been having this problem. It is not related to mental stress, it's the amount of strain we put on the bladder. Like when you're, say for example, a chronic asthmatic, or you've had a very bad viral and you've had a bout of cough which is not abating for 3-4 weeks, you will tend to develop stress incontinence. So, and the third one is a combination of both, where they have both urgency as well as stress incontinence. And these are the types of incontinence generally. Younger women tend to have an overactive bladder, mainly because they're overweight or their fluid habits, like having IT people, for example, they tend to have excess coffee or tea. Shift workers tend to have more tea and coffee, or healthcare professionals, both nurses and doctors, if they are working long hours, they tend to have a coffee break or a tea break. And excess alcohol can lead on to an overactive bladder. But as women age, due to the menopause and decline of hormones and lacking the strength of the pelvic floor, they are more prone for stress urinary incontinence. People with pelvic pain and other things do ask about exercise as well. Is there anything you want to tell them?
A lot of my patients are IT professionals who are sitting for a long time. They sit in front of the computers or laptops for a stretch of almost 6 to 7 hours. They don't get up frequently. Because of the sedentary lifestyle, that is affecting their prostate health and giving them the problems of prostatitis, interstitial cystitis and everything. Exercise helps in a big way. Any kind of physical exercise reduces your anxiety level, reduces your stress level, improves your bladder health and the prostate health in them. So whenever patients come to me, I tell them at least do some kind of physical exercise, at least 45 minutes of walking or 1 hour of some physical activity or some kind of sports which help the patients in getting better.
Absolutely. When you mention sitting, I would like to mention cyclists as well who do cyclothon or general regular long distance cycling. If they have acute bladder pain syndrome, flares or prostatitis, they should refrain from cycling long distances at least for a few weeks and then restart, because that can also worsen. And the type of clothes they wear, very tight underwear, very tight lycra kind of material, which kind of obstructs the breathing of the genital area, will also worsen these symptoms. So with summer coming large at us, we need to educate our patients about what they comfortably can wear during the exercise so that these symptoms don't get worsened. And hydration, I want you to touch upon that for bladder pain syndrome or these kind of patients as well.
Hydration is very important topic, ma'am, because what happens is patients are suffering from increased frequency and urgency and they get scared to drink water. In this scenario, normally what we advise to patients is at least 8 to 10 glasses of water they should be drinking every day to prevent urinary tract infection. But when patients start consuming water when they have an interstitial cystitis or bladder pain syndrome, they get frequently need to use washrooms and they get scared and they stop drinking. But what happens is if they don't drink water, they'll get an add-on urinary tract infections which can again worsen the bladder pain syndrome, again start the inflammation in the bladder which can worsen the things there. So I ask my patients at least drink 8 to 10 glasses of water every day, or at least 2 to 2.5 liters of water every day. Take a lot of lemon juice, at least 2 glasses of lemon juice. Take a lot of probiotics like curd, buttermilk, which can improve your gut health, make it better. Avoid spicy food, avoid red meat, processed meat, and the most important, avoid constipation. Absolutely. Because any patient who is having a constipation can have a very bad bladder health and the prostate health. And if you see, all the things fit in the patients who are my very regular patients called IT professionals, because they sit for a long time, they're very anxious, they smoke, they take a lot of caffeine, they don't drink water, they are constipated, they have a sedentary lifestyle, and the most importantly, they are not sexually active very frequently, or they're not ejaculating frequently. Because whenever patients have prostatitis, they need to ejaculate or have physical relationship at least weekly twice so that the prostate inflammation reduces in them.
Absolutely. And I'm very glad you touched upon intimate health and sexual health. Men and women alike have these preformed, preconceived ideas about sexual health. They think prostatitis, you're going to have sexual transmission and affect the partner or the wife, or it itself is a sexually transmitted disease. Women have the main concept that, after giving birth to the children, after completion of family, there's no sexual life because that's not needed. We need to emphasize that sexual health and intimate health is essential for better urogenital health as well. So that is key element because it keeps the area lubricated, it keeps it healthy, and it keeps it functional. Otherwise, they're more prone for recurrent UTI or prostatitis. Absolutely.
Absolutely, ma'am. And a lot of our patients who are more than 50 years, they stop ejaculating, they stop having intimate relationship. They feel it is, I have elderly kids at home, so how do I make an intimate relationship? But what message we need to give is up to 60 to 65 years of age, your semen production is going to continue. You are going to get semen out. You're going to get healthier. So you should not stop having physical relationship, or at least not stop ejaculating it. So that is very important message what we need to give to the patients, that once you cross 50 doesn't mean that you need to stop having a sexual health or physical intimacy. What we need to give a message to them.
But I also think that is something we need to tell our fellow practitioners as well, to discreetly ask patients regularly during the consultation about their sexual intimacy, sexual health, and frequency of sexual contact. Because if we don't ask, they're not going to come forward because of these misconceptions as well as inhibition they harbor. So I think we need to, as practitioners, we need to be very discreet in asking these questions during our history taking as well.
Ma'am, another question what regularly patients ask us is, if you have a prostate infection which comes up, if I have an intimate relationship with my partner, will I spread that infection to my partner?
That is a very good question because with chronic prostatitis, you don't find these typical bacteria which are grown in the culture, the typical incriminated bugs, but you do get certain other bugs which are notorious for causing genital irritation in the woman. So if the woman keeps complaining of repeated genital irritation, you're not able to find out any particular reason or a bug in their specimen of urine, I generally advise the partner to see a urologist or you to make sure they are not suffering from prostatitis, because these bugs can cause irritation in the partner. So till the time of treatment of prostatitis is finished, they can use a barrier contraceptive and continue to have their sexual intimacy, with the advantage that the prostatitis will be relieved by repeated ejaculation. However, they're not transmitting the same irritation or difficulty to the partner as well. So using a condom at that time would be a sensible way of dealing with this current problem.
Absolutely. And ma'am, one more thing I've noticed is a lot of patients are diabetic these days. Even the young couples of 30, 35 years are diabetic, and they have a lot of infection around the genitalia. It's called ballonopastitis. How does this ballonopastitis can cause recurrent urinary tract infections in women or their partner?
I'm glad you asked that question. As I said earlier, whenever the patients, women are more prone for vulvovaginal candidal infection, or what we commonly call thrush or yeast infection. Now, to educate our viewers, the thrush is classically characterized by a curdy, stringy discharge. It can have a sulfuric odor to the vaginal discharge with excruciating itching and burning and inflamed genitalia. It's unbearably painful sometimes. So when these kind of symptoms happen, one-off is okay, and it's generally after a broad spectrum antibiotic usage for, say, something like a sore throat. They develop this, or they've not been drinking water, or nowadays, as you rightly pointed out, very young diabetics who are on anti-diabetic medications like the gliflozins, SGLT, they can develop this fungal infections because they are excreting glucose in their urine. And in our traditional practice, anybody with symptoms of UTI are advised to take tender coconut water. When they take tender coconut water, it pushes further sugar in the urine, worsening these fungal infections. So people who are uncontrolled diabetics, people who take specific medications for diabetes, who are not hydrating themselves or take anything which is sweet, will be immediately prone for fungal infections like these. So if I find recurrent of fungal infections, I advise the partner or the husband to see the urologist to rule out a prostatitis, because that can be the incriminating factor.
Absolutely, ma'am. Maintaining a good local hygiene is very important. We ask them to clean regularly, and if the things are very bad, we advise them a simple procedure called doing a circumcision, where we remove the front part of the skin. That reduces the transmission of infection to the partner in a big way.
I have this question. Is prostatitis a precursor for cancer of the genital organ?
No, ma'am, absolutely not. Prostatitis can be because of a lot of reasons. The most common reason in present generation is patient time is diabetes, uncontrolled diabetes, or the newer medications, as you said, can cause inflammation. But even patients who are not diabetic can have inflammation around that area. So it's called Zuhn's balanitis, or if somebody has had an intimate relationship with some other partner whom they can get infections around that area. So prostatitis is common in present generation. We can be treated in a proper way. So you need to diagnose that. You need a good local hygiene, and if things don't improve, doing a simple procedure can make their life much, much better. Ma'am, my next question to you is, whenever there's an active fungal infection going on, what advice do you give to your partner or to the men's partner? Do they need to have a physical relationship, or does it worsen the fungal infection in them? Because patients ask me, can I have physical intimacy right now, or should I wait for such long? And how long should they wait?
Good question. No, fungal infection can affect the partner, though we do not call it sexually transmitted disease per se. It can cause similar problems in the genitalia of either of the partners. So when I'm treating an active fungal infection, I treat both of them, both the husband as well as the wife, or both the partners. And then for local relief, we can give local ointments or vaginal pessaries, and similar can be applied for the partner as well. They can use condoms to get rid of the difficulty in not having sexual contact, but at least for a week or two, if they abstain from sexual intimacy, the symptoms get better and the infection doesn't have the risk of cross infection. But abstaining from sexual intimacy is not a solution to prevent the fungal infection, if that is the question. The fungal infection has to be sought out in the terms we need to find the root cause and then improve their gut health balance of bacteria, so they repeatedly do not get these fungal infections in the first place.
Ma'am, you're talking about gut health. How does it affect your bladder? Gut is somewhere else and the bladder is somewhere else. So how do we have connection? Because both in men also, there is a lot of importance given to gut health right now, and there are a lot of UTIs, prostatitis, bladder pain syndrome, everything is related. Even the malignancies are related, cancers are related to the prostate gut health. So can you put a light on what is gut health related to female health right now?
I'm glad you asked this question. Generally, people think that all surgical specialties or surgeons are knife friendly and they do not talk about these important aspects of prevention or lifestyle. I'm glad we're having this conversation. Gut health is so important for well-being of various other organs in the body, including the brain, because there's something called gut-brain axis as well. The gut bacteria is now known to affect your functionality of the brain, including your memory, including your mood. People who are depressed are tend to having more not so good bacteria in the gut. People who are obese completely have a different set of bad bacteria in the gut compared to women or men who are thinner. Men and women who are diabetic have a complete different set of bacteria as opposed to a non-diabetic. So the composition of the gut bacteria, collectively called the gut microbiome, now tends to determine the well being of a human being as such. So it's interesting that we ourselves are made of multitudes of these bugs which keep our balance going. And these are determined the day we are born, the day we are breastfed. Your first antibiotic which you're given tends to change the imprint of the bacteria in your gut. So they talk with each other, these organs, and the gut seems to have a crosstalk with the bladder. Every time the gut is not happy, the bladder also can become quite unhappy, which is why constipation or irritable bowel does have a big say on the way bladder functions as well, as you rightly pointed out earlier.
Absolutely, ma'am. Even what I would say to the general public is, even a course of antibiotics for 5 days can disrupt your gut bacteria for next 6 months. So taking care of gut bacteria is very important. Avoiding the misuse of antibiotics is very important. Ma'am, there is good talking going on in the community about gut health, and gut health is related to everything right now. And everybody is giving a lot of medications to improve the gut health. Is that the only solution to improve the gut health, or do we have anything else to improve the gut health?
Yeah. Thanks the internet, AI, and the influencers, we do have a lot of talk going on about well-being and gut health now, and I'm glad it's all in the stride of well-being. So, but at the same time, we need to understand that all of it is not necessarily a fact, and I do not want that to become yet another dietary fad where people cling on to and then lose interest in. It's something we need to practice day in and day out to improve. So if we can imagine our gut to be like a garden, we need to tend it, we need to nurture it, we need to keep the soil correct, we need to weed it off. Similarly, if you can imagine the gut microbiome to be that way. So for the soil, we need to eat the right type of food. So avoid anything which is processed, which is sugary, which is high in calorie, which is dense in calorie. So all the processed food has extra preservatives. So all these processed flours will have too much carbohydrate in them, which is simple carbohydrate. They tend to overgrow the bad bacteria. But when you eat foods which are called prebiotics, now prebiotics are foodstuffs we take which are cut down in the gut to generate fiber loving bacteria, just like our green banana or the various vegetables which we eat, green leafy vegetables. And these prebiotics, when taken along with the food, enhance the fiber loving bacteria, and that increases our gut microbiome to have healthy microbiomes in them, or the healthy bugs in them, and that tends to preserve our health better. In people who are not having that healthy balance, they will need the supplements which are given from the market as probiotics, because that tends to supply the so-called friendly bacteria like the lactobacillus, which keep our gut balance healthy. Like once said, your skin and your bowel is the mirror of what is internally happening in you. That is what we need to watch out for all the time. So if you do not have constipation or inflamed stools, that means your gut health is good, and that's how we need to nurture our gut bacteria as well.
Absolutely, ma'am. I tend to tell all my patients that taking a bowl of curd every day, or at least buttermilk every day, will keep your gut health and the bladder health better.
At this point, I would like to educate our viewers that curd is what we get set in the house by doing the curdling of the milk, whereas a yogurt is probiotic in nature because it is the culture of the gut-friendly bacteria. So you can make your own probiotic yogurt by adding this yogurt into the curd and starting your own curd culture, which then becomes a probiotic yogurt. You need not necessarily buy every time from an online platform or go to a grocery shop. You can set off your own probiotic yogurt as well. So we've not touched upon issues about genitourinary cancers. How common are they? What are the usual cancers men come up with, and how do we screen them in the first place?
Thanks to all the awareness in the media, or the people are understanding these days that doing a regular checkup, health checkup is very important. And because of that, we have started noticing that a lot of patients are coming to us with very early stage problems right now. So they get a routine checkup called a blood test done called PSA. It's a called prostate specific antigen, which is very specific to prostate. And if it is elevated, they are very smart these days. They come directly to the urologist and show the report saying that my PSA is elevated. What do I do next? Then do regularly ultrasounds and they find out there's some lesion in the kidney, bladder, and they come to the concerning urologist. So what we have started seeing is patients have become aware. They are very aware now. They are very health conscious. They do regular checkups, yearly ones at least. And if there's any change in the values, they come immediately to the doctors. So what I've started noticing is what basic signs and symptoms what I stress upon to the patients is, if you notice blood in the urine, we should not ignore, because even a drop of blood in the urine, don't label it as UTI or the food what you have had. It needs an evaluation. It can be something sinister also. So blood in the urine is very important. Unexplained weight loss is very important. Loss of appetite is very important. Unexplained body pains, because if you notice that your body is aching continuously, your back is aching, or particularly your hip joints are aching very badly, then you need to get evaluated. We have seen a lot of patients who come with PSA levels of 1000, 2000, and they have severe body pain, they've lost appetite, they've lost weight loss, they have severe body pains, and we know that this is a prostate cancer which has spread all to the body.
No, that's very true. I recently saw, I wouldn't call him elderly, he was a young 60-year-old man who had just been on a business trip, had low backache, which was not settling down with painkillers. I went and had a scan done, and that showed up a extensive bone metastasis from a prostatic cancer, which he was unaware of. So, very good point not to ignore pains.
The common message we need to give everybody is have a yearly checkup at least, do a proper ultrasound, do a PSA test if it is anybody who is more than 50 years of age, at least to find out if there's something wrong going on or not.
Absolutely. Very powerful message, because many people think I've had my annual checkup if they call on a standalone lab and get their blood test done. That is not what it means with have an annual checkup. It means the scans, it means certain cancer screening, and going back to your doctor with the reports and following it up, not just having the tests. Thank you for that.
Ma'am, what are the common genitourinary cancers you see and you face every day in your routine practice?
No, we do see a lot of cervical cancers, which is the cancer in the neck of the womb. And thankfully, the best part of it is we now have a vaccine to completely prevent the cancer, which is efficacious in about 100% of the patients. So both boys and girls, right from the age of 9, should have this cancer vaccine in 2 doses if they're less than 14 years of age. Beyond the age of 15, they're needing to have 3 doses of this vaccine, which is protective for lifetime. So this has changed the whole scene now with regards to cervical cancer. We now have an increasing incidence of uterine cancer, where the cancer happens in the body of the uterus, and that's, I would call it, pretty much lifestyle disease, with the increasing patients being overweight, obesity on the rise, high blood pressure, diabetes, and fertility issues. There are many patients now who come with uterine cancer. So any bleeding after menopause, even if it's a single episode like what you mentioned about blood and urine, post menopause you're not supposed to have any blood in the vagina. If it happens, that is immediately to be sought out and addressed and evaluated. It cannot be ignored, because 90% of the uterine cancer present as postmenopausal bleeding. So it's very, very important to understand why that is happening, evaluate and treat it accordingly.
What is the importance of pap smear, ma'am? How commonly it should be done? When should it be done? That is an important message we need to give it to the public.
All women between the age of 21 and 65 should have a pap smear. Unfortunately, in a country like ours, though there are guidelines, we do not have a robust recall system or reminder system for patients to come through to have a pap smear done. So we need to get onto it. So all women between the age of 21 to 65 every 3 years. But now we have the testing of the viral particle as well, which is the reason why the cancer happens in the first place. So thankfully, due to research, I was part of the Manchester University Hospital where this vaccine was first developed. So it's now come a long way for the last 15 years that we have the vaccine in practice. So this a viral particle, if we check and that is negative, we can do it every 5 years. So we need to at least have it every 3 to 5 years as part of our regular health check till the age of 65. Women who have had the uterus removed for benign conditions like fibroid or abnormal bleeding do not need to have any more smears after the hysterectomy which has been done, but the rest we need to have. Now, coming to talk about your reconstructive surgery, how has robotic surgery transformed the landscape in urological surgery and reconstructive procedures, Dr. Sandeep?
Things have changed drastically, ma'am. What we used to do as open surgery, now we do everything, almost all the surgeries in robotic surgery. But what we need to understand is, what people have a misconception is robot does the surgery. No, robot doesn't do the surgery. It is a surgeon who sits on the console, he moves the arms, the robotic arms move inside. If the surgeon stops moving, the robot stops moving. So the misconception is, what people have is the robot does the whole surgery and the surgeon is not there in the theater. No. The one thing we need to make everybody understand, the robot has given us a better precision, better stability, better magnification. There's a less blood loss. Patient's recovery is fantastic. They'd go home very fast. That is the advantages of doing a robotic surgery. Other thing what people have doubt is, with the robotic surgery, will you leave behind the cancer and come out? No. What we do, the concepts, the surgical concept, the surgical care or the patient care is almost same what we do in open surgery. It is just with the small few holes, we can do the same surgery what we used to do in open surgery. So how things have changed is, we started using robot for prostate surgeries, prostatectomies. We have started doing small kidney lesions. It's called partial nephrectomy, where we don't need to remove the whole kidney. We just have to remove the part of the small tumor there, preserve the whole kidney. Third important point where we have started using is reconstructive aspect of patients. So a lot of children start developing something called uretropelvic junction obstruction. It's called pyeloplasty surgeries, where there's a blockage in the kidney and the ureter, the kidney starts swelling up, where we do a robotic pyeloplasty surgeries where the blockage is released. Then other patients where we started using is robotic ureteric reimplants, or patients who have undergone some other surgeries where they have injured the urinary passage or the ureter. There we started using robotic surgery as a tool to make the surgery much more comfortable for the patients. So things are changing, things have got to a better aspect, and now we have something called artificial intelligence and the telesurgery, where I sit in Chennai, I can operate a patient who is in Delhi. So that is a very important thing. This concept can be used in places where there is no robot or the surgeon is not available there. So somebody sitting in some place can operate in a far remote place with a robot there. He can do a telesurgery. That is the thing where we are moving forward.
So literally the mountain comes to the Muhammad. So that's
yes.
Great.
Ma'am, you are known as an international faculty for robotic surgeries, and you have so many awards and publications for robotic surgeries, and you have operated in all the different forms of robots. My question to you is, how has this changed the care given to the patients who are suffering from urogynecology problems, and what do you see in future, how things are going to change?
That's a very interesting question. Definitely robotic surgery, a platform, have revolutionized the way we do gynecological surgeries, and for me it's now become the default go-to procedure for any of my hysterectomies or reconstructive procedures as far as urogynecology is concerned. For urogynecology, it's a boon, this platform, because these women have already had complex surgeries before, have had complications due to those surgeries, multiple incisions in their abdomen, they're obese, they're overweight with other comorbidities. So, doing a big long incision, which is what the practice used to be, and delving deep into the pelvis had its own attendant complications of excess blood loss, longer hospital stay, resultant wound infections, wound complications, prolonged stay leading to other problems like chest infections, clots in veins and lungs, so on and so forth. And the minimum stay used to be 7 to 10 days, if not longer. Now, with the robotic surgery, I'm able to discharge them pretty much like a day case within 24 hours or very next day. Say a complex prolapse surgery where a previous surgery has been done, but the vagina itself is coming down with the bladder. I now do what is called robotic sacropexy, where I anchor the whole thing with a mesh to the bone, and that is patient gets discharged within 24 hours with minimal access keyhole surgery. And the precision is so good, I will be able to tailor the mesh according to the length of the prolapse which is there and anchor it correctly to the bone without further complications. And injury to the neighboring organs, very crucial ones like the ureter, which connects the kidney and the bladder, or the major vessels, or the bladder itself, is minimized because of the 3D magnification and the 360-degree freedom of movement which I get with the robotic instrument. And imagining a huge patient with a high BMI and multiple surgeries to clear off all the adhesions to reach to the depth of the pelvis, this offers a very good platform to perform such procedures with ease. And the beauty about it is it's got a learning curve of 20 to 25 surgeries by which you can become an independent surgeon yourself, but you need to practice on the simulation beforehand. And the next beauty about this whole platform, you can train somebody alongside you on the console, where there can be a double console. And as you rightly put it, with the AI incorporated, the robot itself instructs you as which are the no-go zones, and you're safe within the particular zone where you are prevented from creating any problems or mishaps while you're operating. So that is the beauty of these robotic surgical platforms. But like computers, they are what you give in will be given out. So garbage in, garbage out. So it should be as good as the operator. It just does not make the surgery better on its own. It reduces the complication but does not perform a good surgery on its own. So you have to be a trained person. You have to train yourself better to be able to operate the robot better. So that is the beauty of the whole platform.
That is a right point which you have given, ma'am. Though there is something called robotic certification programs where a person has to train for a minimum hours, get a certification from the robot company so that you have done a successful simulation and you are a safe surgeon. And this is what is going to certify that you are a robotic surgeon and you can do a neat, clean, safe surgery for the patients without any complications.
Now that we've covered all aspects, interesting stuff about urological issues, both in men and women, is there something we need to actually emphasize to our viewers regarding red flag signs, especially for men who have these urinary issues, which they should absolutely not ignore or postpone?
Absolutely, ma'am. That's a very nice question and very important message to people. What are the red flag signs which are very important is anybody noticing blood in the urine is a red flag sign. Second, a diabetic patient complaining of fever, chills or a back pain, that's a red flag sign. Elderly people, disorientation, fall, it's a red flag sign. Patients having recurrent urinary tract infections, unexplained, we don't have a reason for it. We need to evaluate. That is a red flag sign that you must be having some other abnormality, and just right away just taking antibiotics is not the solution for you. So these are the important things which we need to stress about.
Absolutely.
And what are the red flag signs in your patients, ma'am? What do you see? What do you feel that if I feel that these are the symptoms and signs patients are coming and this is really an emergency for the patient?
Yeah. Blood and urine, as you rightly put, people attribute it to the food or the heat typically, or not, I have not been hydrated. Blood and urine, bleeding after menopause, bleeding in and around menopause time, which is heavy or frequent. People assume menopause, you will have erratic periods, but that is more infrequent and scanty. If you continue to have heavy periods or continuous periods, that is not menopause. This is a red flag sign with which you immediately need to go and see the gynecologist. Any lumps in the breast, any difference in the breast structure, or any discharge from the nipple, or any abnormal discharge from the vagina which is foul smelling, which is not reduced at all, any loss of appetite, any gastro symptoms which have not settled for 2 weeks, especially middle-aged and beyond, if they have indigestion symptoms, burping or feeling of reflux all the time for at least 2 weeks, they should immediately see to rule out an ovarian malignancy, because ovarian cancer is a silent killer. It does not present itself in the first stages like the other cancers, but these kind of gastrointestinal symptoms could be a marker for ovarian malignancy, so something we should not ignore. And rightly put earlier on, loss of appetite, sudden loss of weight, feeling extremely tired, or recurrent urinary symptoms in a diabetic should not be ignored at all, and these are red flag signs.
And what is the final message you want to give to the public?
Women need to respect themselves, listen to their bodies, and practice self-care. It's not something you are not selfish and therefore you do not look after yourself. So do not ignore symptoms which you're not comfortable with. You know your body better. So if you're not feeling up to it, even if it means fatigue, that could mean something very important. So please consult your family doctor or a specialist to find out why you're not yourself in the first place, and address it immediately without procrastination. Procrastination is the reason behind many health issues, especially among women, and that has to be stopped.
Absolutely, the same thing goes to the men. I feel they should not suffer in silence. Do not normalize things that, okay, this is just an aging process. Third, there will be a lot of burdens, there will be a lot of stress in family, but taking care of your health is utmost importance, because if you are there healthy, the whole family will be healthy. And the most important point, have a regular yearly checkup, at least to make sure that we are not missing anything sinister.
Absolutely. Absolutely. I think it's a wonderful message that both men and women alike should learn to fly, which stands for first love yourself.
100% agree to that, ma'am.
Absolutely.